Okay, hi everyone. We're going to start the second workshop now, and I'm going to keep talking until all the corners have quietened down. Thank you. I'm Stuart Smith from the Hepatitis C Trust, and today I'm going to try and generate ideas and discussion around innovative approaches to case finding. I think one term that I'm really getting behind at the moment is beyond the services. I think we've done a fantastic job, mainly drug services and everyone involved and the partners involved in moving those along so that we are hearing micro elimination. I'm hearing every day new sites. I spoke to an ODN manager last night. She was aware of her 12 drug services and 7 or 8 of them had reached micro elimination and the rest had 2 to go or 3 patients to go. So we are an incredible place. And I'm just going to ask a quick question. Has anyone heard of the words unmet need in the context of commissioning drug and alcohol services? Did Sean warm you up so you'd be putting your hands up? Unmet need, anybody heard that term? So I was hoping someone else could give me their definition. I'll give you my rough definition. So back in the days of the NTA, the National Treatment Agency, there was a lot of modelling done to work out how many drug users they felt were in services and how many were not in services, and they called that the unmet need. They modelled it, and that you could actually pull down graphs in all your commissioned areas around the country to work out what this model said. They estimated the amount of people who weren't in your services. Just to sort of give you the answer, it's 50%, you know, because it's not an exact science, and I would go around and some areas were 40% and some were 60. It all sits around 50%. So that was their thinking decades ago. We're not sure if that's still the same. We're not sure if there's still half the people are using out there who aren't in touch with our services. And in fact, OHID are starting on a new program of work to try and re-explore unmet need. So, but the reason I'm talking today about innovation is I want to think beyond the services now. And it's going to be quite peer focused, my discussion. I've got some data from the peer programs to share with you. But while I'm talking, because I'm just leading us down one road, which is the peer road, I would like you to start thinking about examples in your areas where you have gone beyond the services. You've gone out and tested a food bank and you've used certain thick woolly socks as the incentive, and it worked really well and you gain trust. I know you've all got examples, and today I'd like to just some discussion around and that, so we can listen and learn and maybe share. So I've written down some on here, which is community pharmacy NSP sites. So they're an obvious sort of next step for touchstones to try and meet the target patients that we think should get tested. Track and trace, I'm a huge fan of that model, and I think we will be seeing more of that, especially at the Hepatitis C Trust as we go. Networks of injecting drug users, that is basically what we're talking about. We want to get in amongst that network and try and encourage people and their friends to come forward for testing. Bring a friend. And I'll talk briefly about our HCV ambassadors model that we are being commissioned alongside the Drug and Alcohol Commissioners in Bournemouth to try or to pilot. So last night when I was trying to prep these slides out, I dug some data around from our own patient management system. And if you add a patient to the Hep C Trust peer support patient management system, you cannot add them until you've said, where did we find this patient? So this first graph, and I'm hoping that you can all see it, shows where we're finding our patients. And I'm going to show you that I can't actually see very well, so I've been down here. The beige lines are clinic referrals. So many of you will know when we are we've developed such good relationships with clinical teams that they're often saying we've got another person who's positive and they'd love to get support so they can come back to and through their treatment with you. So the beige line shows that these are sort of nurses who have referred as patients. The pink line is drug services, and many of you will know that drug services have leaned into the peer program and does with them and work together. So the pink shows people who have found in drug services, and the drug service has referred them to us for our peer support. And okay, so the only other one of importance I want to talk about, they're all important, but the one I want to talk about is the top one, which is a pale blue, and that is our outreach interventions. So I suppose what I'm trying to show with this graph, which goes back about 18 months, so it's monthly, it's got about 18 months of where we're finding patients. What you can see here is it hasn't changed, actually. And what we know is that for the next 2 years going forward, we do need to change, because we've done an amazing job in drug services. And I'm going to always take my hat off to the work that's happened in the last 5 years plus to get us to the micro-elimination. But now we can't just sit there. And for me, we have to go beyond the services. So at the Hep C Trust, I want to see that blue line becoming a much bigger proportion of where we're finding our patients, and not just going about everyday business, which the numbers will be dropping if we just continue to do the same in the people we find. The next graph I dug out is we ask a question of our patients: are you currently a client of a drug service? And the pale blue here shows that most of our patients are already engaged with a drug service. So these are most of the patients that our peer program supports. And in fact, interestingly, if you look at the bottom one, it says the area is called no value. And that's because our charity has a system where we got given 25 teams, and there's a lot of ODNs, and we've got Wales and Scotland to support. So the no value is prison. And that's not a reflection. We haven't named prison as no value for any other reason than it just hasn't got a team. But what I want to show here is even in our prison work, most of them are in drug services. So unless we step beyond drug services, and if there is actually an unmet need, then we are just kind of continuing to do what's in front of us. And I would say that we probably need to be moving beyond that now, especially for the peer program, where we can actually do that. But we are probably going to be able to do that alongside drug services, because many of them do have a passion to also address the unmet need that's beyond their front door. The next chart I'm going to show, because I am going to stop talking in a minute and ask you for your examples of innovation. I took hours drawing this graph last night. I'd just like to say that. And to the point where I just suddenly looked up from my computer and thought, well, you haven't even done your presentation. What, you've just been doing Photoshop for the last 2 hours. And it's come out how it's come out. I want to show on this graph, so the blue line, I really want to show the number of patients in drug services who are still sat there positive, but really it's an indicator of micro-elimination. So if you can see from 2023, the blue line going down and down and down, to me in my head, that's all the drug services that are calling micro-elimination. So the number of people sat in services with Hep C is going down and down and down, and that's fantastic. But the red line is what I want to see us doing at the peer program. So instead of supporting the drug services so much, and even the clinics so much, we're doing a capacity review of how much time we spend on different activities. And it's very ranged, because we have a lot of autonomy to the peer program to meet the need of that area, if you like. So what we do in one area can be different to what we do in another area. But what we want to try and do is make some protected time for our peer programs to do these innovative new approaches, the bring of friends, the going out on the high streets, the working with the street homeless. So that's what this graph is showing. And then my final slide, to get you to start thinking about our discussion, Can you give examples and results of any innovative outreach you've done in your area? So did you at WHD, World Hepatitis Day, go and to a sex worker community and test 30 women and get 6 positives? So I would like to hear about kind of things like that you've done. I know you've all done different things and lots of very, very good work. Do you know where your high footfall of NSP pharmacies are? So every ODN, every city has got a favourite pharmacy by drug user choice, and you'll find that it's got a very high footfall. You know, have you been there? You might want to come back to me today and say, actually, we targeted a pharmacy and we got really good results, or we didn't. And in fact, what happened in the previous group just now is we heard about examples where we got no results, and they're just as valid because we need to be quite targeted. So knowing where not to go can be just as important as knowing where to go. And the answer to that was immigration centres, by the way. So I'm not going to go on record and say don't go there, but I still have yet to see any positives come from those big testing of immigration removal centres, migrant centres. In the group before, went in, tested 500, 0 positives. Another ODN went in and tested 95, 0 positives. They did get hepatitis B, they did get HIV, but we are talking about Hep C, and I would suggest that, you know, if you are going to target, you might just want to look at where other ODNs have not been successful as well. But you have to try. Do you have bring a friend interventions? And many of you will have done variations of this bring a friend is called, and how successful have they been? And finally, what percentage of drug services in your area have almost reached micro-elimination? And, you know, it'd be good to hear, because if you feel that you are there or almost there, then these 3 questions above are the ones that we need to be thinking about next. So I'm going to stop talking, and I'm going to ask, please, for you just to raise hands. I might scribble some notes, and please bring to me any interventions that you've done in recent times that have been successful, or ones that haven't been successful. Right in the corner with the lady in the black top.
Sorry, I'm from South Warwickshire, and we've nearly achieved micro-elimination, and we've been doing those targeted pharmacy events, finding out from CGL who is being prescribed, which are the most popular pharmacies being prescribed at. And I had this amazing initiative. In Leamington, there used to be a festival called the Peace Festival, and you'd get lots of people that probably potentially had some risky behaviour in the 70s and 80s, and they would all congregate in this Peace Festival, and they stopped it. So just as I'd got everything together, it just didn't go ahead this year. But that would have been an amazing event. No, it wasn't on last year either. It never came back from COVID. But I think it would have been a really good opportunity to kind of get some, even just to raise awareness amongst that kind of group of people. So yeah, and we're trying to do more initiatives. There's a service in Stratford that's got a homeless project, housing project, food bank. So we often do testing events there with vouchers.
Do you get positivity?
Yeah.
Okay.
Not loads, but
okay.
It's hitting that data.
Okay.
Of people that haven't been tested within the last 12 months or whatever.
Good. Thank you for that. Any other examples of work that you've done in your area?
So I've got a couple from Nottingham. So we've got a health bus which goes out everywhere and will pull up anywhere. Side of the road, as the car park's really good when everyone begs outside the big car park in the city. Loads and loads of people that access drug treatment. It's been really, really good. And because it's a trusted vehicle now, people will come out looking for us, which has been dead good. We put some stuff out at the Nottingham Mellow as well recently. That was really well taken. Right. So that was really good. And we're very fortunate to be part of this SIP project. So we're starting to give out crack pipes as part of a research project. And that's bringing loads of people that we've never seen before, which has been brilliant. And again, the pharmacy, so really good testing events in some of the big pharmacies, well, kind of in the city as well.
So one of the things that came out was very similar to that from the group before was they had a mobile van. They said, look attractive, so make the van look good and be attractive in what else you can hand out. So by handing out things like crack pipes that people want, it gives you the opportunity to start building up trust and then do testing alongside.
I would agree, but the opposite for us is we're not attractive. So we have a highway maintenance vehicle, so it's very discreet, so it means we can go anywhere with a little orange light on the back. So it just says health bus, it's not branded, so there's no problems with partners on it doesn't say NHS or framework in case one person likes one service, won't come because they're not that service. So it's kind of very neutral, not dead shiny apart from the light on the top.
So by being undercover, you are attractive.
Yeah, because we pull up outside a crack house, say, and no one kind of knows what we're doing, and it can be really discreet, and people can come out without kind of it being like flashy kind of thing on the side. So yeah.
Okay, thank you for that. Yeah.
You have
I'll come across back to you guys next.
Thank you very much.
I might let you actually choose people, and then no one will get resentment towards me.
Yeah, hi. My name is Sarah. I'm from the Hep C Trust. What's worked well recently is going out and working collaboratively with local drug agencies late at night. So we started at 8 and worked till 11. And we had the Find and Treat the NHS with us as well. So we were able to do all of the tests there and then. So the NHS were really happy with that. But we were also able to get SVRs and follow-ups immediately. And then the local drug agency were giving out, little parcels for the homeless. So that worked really well.
Okay, that's a very good point, the timing. So is there anyone here who works in an ODN where you're not aware that you've done any out-of-hours work, evening work? Do you feel that you're all doing that? Because I think timing is very important. If you've only been working in office hours, for example, for 5 years, then you are probably going to have missed a whole bunch of people who only come out in the evenings. So it's a really good point. Thank you for the timing. Yeah.
Just to your point earlier about immigration, so on World Hep Day, a week, should I say, we went to a hotel in Blackpool. We tested 270 migrants, not one positive. Later on that evening, we did the Street Angels, where they feed the homeless in the night, and we got tested 37 and 6 positives. So it just goes to show where the area of positives are, like say in the evenings, homeless. And we have Sean, who's our Hep C peer, and does the homeless, and he does the evening ones, and he's seeing a lot of positives in the homeless area. So I think that is a big area that we should be targeting, is the homeless.
So you just hit to in very succinctly. Thank you. You have to do it, and of course you do. But as I think the clock will be ticking. We are likely to have 2 more years where everyone in this room has got like decent amount of resource in comparison to public services at the moment, and unless we take advantage and go to the right places, we are going to leave people behind essentially. So you've got your hand up for something. Go on.
So I'm Debbie Moores from Humankind. So Mark Burns and myself from Hep C Trust, we cover in Burton-on-Trent in Staffordshire. So we did a hit early in March 2021. We did the NAP project and tested 67 and didn't get a single positive. And we're finding hardly any positives in the service at all. Every single person has been treated. We've just got one lady with a valid reason.
Good.
But there's a rehab 600 metres down the road from the drug service. So at any one time, they've got like 50 people who are accessing that rehab. They've come from all over the country. But when they relapse and they leave, they're all staying in Burton-on-Trent. So we went and tested 47. We went and tested 47 people in one day, and we only had one antibody positive, and that was from a lady who'd been treated herself about 14 years ago. So she's now agreed to be the Hep C champion for that rehab. So, because obviously you're testing everybody on that day, It could all change by midnight. You know, you've only got to get one person coming in who could contaminate a lot
Yeah.
of other people. So it is something that we're going to continue. Yeah, but
Okay.
no, not one positive.
Jonathan in the back.
Yeah, I was just going to mention as well, because even though, like you said, we have done a good job in drug services, even within drug services, adjusting the times that we're trying to contact people and go out could be massive. My team have started working a lot from 5 till 7 in the evening just to try and contact people and book them. And we're getting people who we've never got before, who miss loads of appointments. We get them tested, and we're finding a really high percentage of positives in them last few clients that we need to get through the door.
Okay, that's interesting. Thank you. We're working gently across to you, James.
Hi, I'm Lisa. I'm one of the viral nurses at Derby, and we went to a large mosque in Derby City Centre. We tested 140, mainly men and a few women. We got one positive antibody, and they'd been treated previously.
So is that an example of where we might not want to be focusing, do you think, then?
Yeah.
Right.
Yeah.
Yeah. Okay. Okay. No, it's good. It's good. So, James, you've had your hand up patiently.
Thank you. Yeah, so primarily from the partnership support, the Rough Sleepers initiatives that we've worked with, we generally hold a weekly or bi-weekly meeting with them. So any patients that we know are rough sleeping, where they've also got the camps as well, it's that whole round support. The number of times we've gone, oh, we know about that person, or they're in hospital. But likewise with Rod, going into food banks in the evenings, working out in the rural county areas where they don't have NSP services, where they don't have drug services, utilising the van, utilising whatever else. Yeah, the nurses as well.
So how do you know where to go then?
What I do, I just attend like networking events. My local knowledge and all, being from Leicester and being a service user in the past, I sort of know these places and the people, and I've come across people over the years. So I'd go to the networking events and just to promote our work and to see, well, basically see where we can help each other. Or just cold calling. Like last week, I went over to a rural area where there's no NSP or drug service, and I just approached the pharmacies. And while I was out there, they informed me of a local food bank. So I've set up a testing event for beginning of October for that. Okay. So it's just being on the ground and asking. Yeah, just being there.
Okay, thank you. Great. You've got your hand up as well?
Sorry. Steps in. Thank you.
So I don't know if it's in terms of, we always talk about in our service that you can't always place a value on information that you give out. So I think we've done quite a lot of going to all kinds of different places, and sometimes find you don't get a lot back from in terms of results, but that you pick up people who probably have been at quite a lot of risk and haven't realised. And then sometimes it's good to test people and know that they're negative, but also, so for example, we went to our local Pride last year. We took a testing van, didn't do many tests, didn't get any positive results back off that, but gave out an absolute ton of information and realised we were really underprepared in our, like, how do we give this information to people game. So like we're going back this year, and it's like it's spot on our information giving game and like what stuff you can give people to go away, because as well, in our area, people are quite reserved and are not. If you kind of go up to them and say, hey, it's a really good idea for everybody to get tested for Hep C or all these risks, they just kind of can go really inward and won't respond to that. But if you give people information and the ability to contact you or use now the web portal, that you can't just take into account what happens on the day. You've got to think about the trickle down and also the things that are so like on Hep C week, I got interviewed on BBC Radio Cumbria. Was quite surprised to find when I dialed in that I was live and hadn't been given the questions before, which threw me and probably affected the quality. I was also on the TV. And they did edit some bits that I would have liked them to have kept in, but it's about that where you're getting the. So what we find that when we do like a big project, it creates media attention,
Yeah.
and there's some kind of things like so. I've said Cumbria crack about 5 times today, but there was a point at which we were doing testing events on a Saturday, just going to different places, and we did Carlisle Market Hall. We had the stall near the toilet because everybody passes there, and we tested quite a few people, and we did a few when we were building up the thing. But then the one that we did after Cumbria crack, people were coming on purpose, and it's like, I've seen you on, and I want testing.
Good, yeah.
So it's just the follow on from.
I think you're
what
right. So one of the when we first started the peer program, we just gave out information. That's what we were doing. It was the interferon days. We were impartial as whether you did interferon or not, but we wanted you to become aware of your status and at least know about your liver. And so what we called those numbers was the indirect benefits, because we'd do awareness workshops. We know people would tell friends and get tested. Someone would get tested as a result, but it's very hard to quantify it. So I'm a big fan. And we did Pride Festival in London this year and chose to direct people to the web testing portal that was mentioned this morning. So instead of sort of saying, you know, get a test, we were just there to give information, and we generated a lot of discussion around the stall. And I expect a lot of people did take the QR code and go and get a test ultimately, but we weren't. Okay. Okay, good. Glad someone's making a list. That's good. So provide information. So just before we close, anyone done any specific bring a friend work where you actually sat down and thought, we're going to like put an intervention together, we're going to maybe incentivize it, maybe not? Yeah.
This is the worst bit, is speaking into this. This is Ben and I'm
Hi.
Sarah. Hello. And we're from SIAS. This man is just amazing, absolutely amazing. You have lived and, I know you won't mind saying, used on the patch that we work in now. Your local knowledge and understanding is the basis on everything that we have achieved.
Okay.
We're not quite at micro elimination, but I have been sending emails with names and numbers on. But we've had clients that have literally come in and said, okay, they've been KEFI tested when we had a KEFI test machine on loan, and they have quite literally bought in the people to which they use with. And if they wouldn't come in, they have openly given us the names of those clients so we can target them and get them into treatment. We had one gentleman who came in, and he quite literally, for about a week after, was bringing in random people saying,
Okay.
right, test them. I've shared a
Good.
crack pipe with him. He shared a crack pipe with him,
Right.
and he's shared a crack pipe with him, and he's positive. So, and they've helped us target so many people and highlighted webs of pockets of users, and they've just been the basis. And I think the majority of the time it's the relationships that you build with our service users.
Yeah.
I think it's very easy to get carried away, especially with micro elimination, about numbers. But at the end of the day, it's people behind that. And you have to think on your feet. Ben's setting up a testing clinic at a local gym, because let's target steroid users as well as something different. Ben also does the needle exchange, working with high intensity needle exchange provision. I've walked through crack dens. We've tested people through windows.
Better stop there, I think.
It's brilliant. It's the most exciting. It's as a nurse,
Yeah.
this is the best that it can ever be. Is testing people.
That's a great example.
Making a difference.
Yeah.
It doesn't matter where it is.
Yeah.
Quite literally, out of a toilet window, dangle your finger here.
Very good. And so got 10 minutes. So we tend to decide to let those people have fun rather than like tell them they got Hep C. But so, like I say about the Pride, we made a decision rather than give someone a diagnosis, a rapid test, they're there to party. But so someone mentioned it really well earlier. You start with the information, and something triggers. Oh, what? I can take a picture of that QR code, can I? And maybe so. Who knows? 5 days later, they might have just ordered a test for themselves. So it's very hard to measure those indirect benefits, but they are definitely, that is a very valuable intervention and building up the trust. I love what that table had to say. Is there any more? Who else has done a Bring a Friend initiative? Yeah. You can have this one.
Hiya. I work with I'm Sam from Nottingham. So we've been doing a community pharmacy project, which is running quite well. Initially, we were doing the Bring a Friend thing as part of that, but actually found it was working a little bit too well. Particularly on one event, we had a couple of people turn up who were then bringing family members over, which was great, but we ended up testing over 80 people over 2 days at that site. And none of them would necessarily target patients because we're quite open to testing anybody who basically wants to come for one. So kind of learning from that was, well, yes, incentivize, but be careful how you incentivize. We've done it with a few times with people who've obviously come in for testing that have been on script and things like that. And we've said, well, my partner could really do for a test, but she won't come in. I was like, well, tell you what, bring your partner in, we'll give you an extra voucher, and boom, they're out the door and back again in a flash. So it does work, definitely. But I think also there's an element of being careful around that. And something else that we've discovered with the pharmacies is, being a pharmacy technician myself, is I can go into those pharmacists and kind of, because I can speak the lingo, we get a bit more engagement, and certainly we're making some roads into some of the larger chains now, which is quite exciting. From that perspective, there's certainly something to be said there for going into pharmacies and doing this. And we have had quite good numbers, and quite uniquely, like I say, we don't just target the patients that are on script. We will have anybody in for a test who wants to come for one, be that, script staff or, just a general, somebody who's walked in off the street. And we have found some quite interesting cases and some quite interesting information from people from having that approach.
Good, yeah. I mean, you do have to use incentives, carefully and cleverly, and thought has to go into it for sure. And there's been a lot of examples of good practice with them. And then there's been, I remember when we first did it in London, someone just went around the corner and tried to disguise themselves, didn't do a very good job, and came back for another test. So you are, we have something that we're trying to develop now called the Ambassadors Project. That's just the name for it, but it's quite a simple concept, really. It's not our concept. But the idea is that on the day, we're down in high footfall areas, and we can recruit people to go and bring friends for us on the day. There is an incentive attached, and it's done within, the right governance and protocol. But you have to be quite on it when you're doing that. You're dealing with people who will, who want vouchers essentially, and you've only got a limited amount, and you want to get, positives really. You want to get, that's a good example. And so, anyone else with Bring a Friend? Carrie, are you going to tell us what you've done Bring a Friend wise, or track and trace?
I felt like it would be a little bit of a travesty if I didn't mention it. So over in the Northeast ODN, we have at the Hepatitis C Trust been fortunate enough to have funding from the Freeman Hospital, particularly for this programme. The difference, or the niche aspect, I suppose, is that it focuses specifically on those patients who are reinfected. So an index patient, who is somebody who has been infected at least once before with the virus, is then referred across to our programme, and the Bring a Friend model is utilised at that point. It is incentivised, and within that particular cohort, it's showed it's shown absolutely tremendous results. The ratio, I mean, I don't have them to hand, but the ratio of positives is, we're talking over 50%. And that's PCR in terms of those patients that are brought via those people. And it's also been really, really good in identifying the kind of other challenges that are going on with those people. A lot of them are not in treatment, as in substance misuse treatment. They are in populations that are perhaps a bit further away from services. So it's highlighted a lot of other things as well. So I just wanted to put that out there.
Thank you. Yeah, that's and that is a published piece as well, isn't it? The track and trace in the North East, so you can go and find out how they went about doing that. Is it good practice to put someone on the spot at these things? Because I'm looking at the lady in green at the back, who I know is involved in the drug services in a big way, and I wondered, have you had any thoughts? You can choose not to answer, Tracy. Have you had any thoughts about how you might move beyond what's coming through the door? How do you deal with the multiple like NSP contracts that CGL actually hold to deliver NSP to clients who aren't actually coming to the high street, service?
So a lot of the thought right now is around years 6 and 7 and what will that look like? And you're absolutely right, Stuart, it is looking beyond what we do now, because we know that what we do really well. But there's people out there that we don't have access to. So 2 of the big ticket items, let's say, is NSP and pharmacies. We are in a position where we've got some real fruitful and useful data around pharmacy provision, looking at within local services, which pharmacies do we have already, let's say, subcontract in place for them to deliver NSP. So they're a natural kind of go-to around conversation of how can we kind of develop and build upon. But what we're getting is a lot of resistance. So pharmacies that are now telling us that they don't know whether they can continue to deliver NSP on our behalf via a subcontract agreement. But then also the costs that will be occurred to the drug treatment services to go in and use facilities to test. So whilst pharmacies is a huge big ticket item in terms of what happens beyond, lots of barriers, and so we're currently trying to think about how do we address that. Is it that we go to the top? Do we go kind of stay locally and go to kind of your LPCs? So I'd be interested to hear from anybody in the room who's maybe experiencing something similar, or maybe even works in a pharmacy, to help us kind of unpick some of those barriers. And then specifically in relation to our needle and syringe programmes, both in drug treatment services and those that deliver in pharmacies, it's the power of the peers. We need people to take us to where are the groups? Why aren't people coming into our NSPs? Because they're not. Footfall is becoming less and less. So what are people doing? The risks are still very much out there. So they're kind of the 2 big ticket items that we're looking at in terms of years 6 and 7 and beyond what we currently do now.
Well, I think we heard the value of lived experience from Ben over there in the corner, and there is some sort of undercurrent rumour that the Hep C Trust peer programme is going to be moving away from drug services. That's not actually accurate, and actually what you've just said, Tracy, is an opportunity for us to work with you, so that we are beyond the borders a little bit more. But we are happy to be those people. If you haven't got the resource to be in the pharmacies, we're happy to work with you towards that. So I think we're going to close the session.
Thank you.
Hopefully someone's heard something innovative and new in our discussions, and we will be watch this space really, and we're going to use HCV Action obviously to try and publish new and interesting interventions as we see that they are working or not. So thank you.